Hello. So the title of our talk is Exploring the Potential of a Pretend Play Intervention in Young Patients with Leukemia. And we have an international
Yeah.
team.
Can you maximize your PPT?
Say that again?
Can you enlarge your PPT?
Steffi, du musst den Dozierendenmodus.
Ja, I try. I try again. So
Sieht
now it
gut
works.
aus.
Okay.
Yes.
Perfect.
All right, thank you. So we have an international team. Myself, I'm from Case Western Reserve University in Cleveland, Ohio. Dr. Frigner Holm from Uppsala University in Sweden, and Dr. Julia Quitman and Dr. Stephanie Witt, who are both from the University Medical Center, Hamburg. I want to note that Professor Matt Hansen, who is professor of biomedical ethics at Uppsala University, really came up with the idea for this project as he held ethical rounds with the staff at the pediatric oncology wards. He asked himself, where are the children's voices and how can we help children be heard in the care situation? Next slide. Whoops. There we go. The overall aim of the project was to explore pretend play as a resource for children with cancer and to evaluate if the intervention can increase participation in the care, self-efficacy in the care situation, and well-being and quality of life. In developing a new and complex intervention, it is important to pilot the procedures throughout the various stages. Next slide. I want to give a brief overview of pretend play in general. And the next slide. How does pretend play help children? Pretend play itself involves imagination, narration, developing a story, and emotional expression in children usually from 3 to 10 years of age. And in general, engaging in pretend play helps children deal with life's challenges and stressors by, this is a place, first of all, where they generate coping strategies and practice and rehearse problem-solving approaches. Also in pretend play, there is emotional expression and emotional processing, which helps with mood regulation in children. And finally, in pretend play, children experience control and agency, which is so important in the hospital setting where children have little control. Next slide. So in medical settings, there is a body of research that has found that, first of all, pretend play reduces fears and anxiety of hospital and medical procedures. Also, play has reduced pain complaints, and play has fostered coping strategies. If you target the particular issues that these children are dealing with and help them develop coping strategies through the pretend play, it helps them deal with the particular stressor that they're struggling with. Next slide. So as we developed this international collaboration, there were a few lessons that we learned during this process. First of all, it is important to consult with experts who work with a specific child population, in this case, leukemia, to learn what the common issues are that these children deal with, so that the pretend play intervention can target those specific problems. And second, we put together a team of experts with different areas of expertise to design the study. So, for example, individuals who really knew that child population, individuals who had expertise in the area of children's play, in measurement, in statistics, research design. So that team is important. And finally, persistence as you work through problems, and frequent communication. So now moving on to the specifics of the study. The studies was carried out in Sweden and in Germany. So I turn this over now to Dr. Witt and Dr. Quidman.
Thank you, Sandy. Yeah, I'm happy to present the first study from Sweden. It was a feasibility study, and the specific aim, next slide, the specific aim of this study was to develop and evaluate the feasibility and acceptability of such a pretend play intervention, which was targeted for young children with cancer. This first feasibility study was conducted in Sweden by our colleague who unfortunately cannot be here today because of teaching issues, but I'm trying to present her her results as good as possible. So this in this feasibility study, 4 patients were involved, and all of these 4 patients were in active treatment for their cancer disease. And the intervention administered for this pretend play consisted of 6 to 8 sessions, which lasted approximately around half an hour. And the play sessions took place either in the child's home or at the hospital, depending on what worked better for the children or whatever suited best for the families. And the play facilitator and the children were alone in the room, and all sessions were video recorded. And the overall results from this little feasibility study suggest that the pretend play intervention was really enjoyable for the children. And the measures we've used indicated only small improvements regarding self-efficacy in care situations. But we found also increased quality of life in the children. And the main finding was that no adverse events or increased worrying was reported in conjunction with the play intervention. And therefore, first, the intervention was regarded as safe, also as feasible and also acceptable, as reported by the participants and their primary or main caregivers. So this was the first study which was done in Sweden, and now I'm happy to present you a little study which we've done in Germany. It was also like a pre-study which we've done. Before we tested the pretend play intervention in practice, we wanted to make sure that we considered the most important or the specific aspects which are important to the young pediatric oncology patients, and then we try to integrate them in the concept. So for this, it was essential for us to really grasp both perspectives, to really ask the experts in the field of the pediatric oncology and also affected parents of young patients. And on the one hand, we aim to gain knowledge from parents and professionals about the children's resources, about the children's burdens, and also their ability to pretend play. And on the other hand, we aim to prepare the initiation of such a pretend play intervention in Germany based on the child's needs, on the parents' needs, and on the professional feedback. So we conducted individual face-to-face interviews with 13 parents of children diagnosed with leukemia and 15 professionals working in the field of pediatric oncology. And the parents of the children, or the parents we asked, had children aged between 3 and 13 years. And the professional background was either being nurses, being physicians or pediatricians, being social workers or pedagogues, and psychologists working in the field of pediatric oncology. And the interviews we conducted included questions about the everyday life of the children, their burdens and needs, their coping strategies, psychosocial need for psychosocial support, and especially a description, more or less a description about the pretend play and their opinion on that. So these are the themes emerging from the analysis. So these were more or less 5 themes, and I'll be happy to walk you through these themes. Theme 1 is the ability to play in the context of leukemia. And both parents and professionals emphasized the reduced opportunities to play in young oncology patients. This includes the restrictions and limitations caused by physical aspects, resulting in reduced quality of life, like side effects, physical weakness, or loss of concentration. Pain and physical limitations appear to be also a limiting aspect of cancer on being able to play. And maintaining social contacts with friends was reported to be a really frustrating aspect for the children to undertake, simply because they did not have the energy or didn't feel well enough to interact with their friends, to meet their friends, to go to school, to go to kindergarten. And also the games that children played while undergoing acute treatment were reported by parents to be mostly isolated. Passive activities such as just watching TV or playing movies, playing video games on the tablet or smartphones, or reading books, for example. And the lack of exposure to playing was viewed as really a possible disadvantage, because the children do not learn how to interact, or weren't able to interact with peers and to resolve conflicts. The next theme emerging was the way of coping with leukemia. And parents and professionals focused on the various ways children cope with leukemia, its treatment, and its consequences. And the main coping strategies that parents reported included avoidance, acceptance, withdrawal, isolation, aggression, and rebellion. And the parents really described their children as being sometimes apathetic and withdrawn, and emphasized distraction and repression by mainly digital media, as I just told you before. Additionally, parents talked about religion as an applied coping strategy, which none of the professionals talked about. In other situations, parents described their children to show aggression, such as screaming. They were kind of like furious and irritated, and professionals confirmed some of the same coping strategies that parents reported, such as distraction, withdrawal, and isolation. The third theme is the difficulty to transitioning back to normality, and the transition from receiving intense treatment to maintenance therapy, and therefore living a more regular everyday life again, has been described by parents to be quite complicated for the parents as well as for the children. Parents reported feeling overwhelmed because they find it hard to settle back into normality, and this is because of the fear that their children's health will worsen again, or that they have a relapse, and some have difficulties looking at their children as a healthy and not anymore sick child that requires help and treatment. And at the same time, parents wished to treat their children as they did before they came ill, and to establish some kind of normality, I guess, again. And this inner conflict was quite difficult to resolve for many parents, and it, of course, had effects on the children themselves. And the parents of very young children reported that the illness had extremely delayed critical development steps for the children too. So, for example, again, interacting with peers became a big challenge for the children. Professionals, on the other side, emphasize that there are substantial support resources for both the children and their families during the acute treatment. However, the presence of the services during maintenance therapy were depending on the number of resources available and could also be very limited. So professional follow-up care is established, but existing systems do not always sufficiently cover the parental and the child's needs. The fourth theme is more or less the parental quality of life and the parent needs. And despite the focus of the interview, that this was about to be about the child and the child needs, we found specific findings on the parents' enormous burden. The parents emphasized that the demands and burdens that are brought by the disease have an impact on the entire family. So therefore, it's important to really try to help everyone in order to help the child adapt again. So the parents or families' life were reported to have changed abruptly. New short, medium, and long-term planning and quick adaptation to sudden or new situations were reported. And because of this, parents experienced feelings of helplessness. They described existential fears about the child's life, which they tried to forget. And sometimes, or specifically, parents would try not to show their fear in the presence of the children. But of course, the children felt something like this. So nevertheless, feeling fearful was expressed to be a permanent occurrence in their everyday life. And additionally, parents were afraid of possible long-term consequences and relapses. And then the fifth theme is the perception of the potential of such pretend play intervention, and both parents and professionals appreciated really the idea of a pretend play intervention, especially for the young children. They emphasized that creative fantasy play under professional supervision could only improve well-being and coping skills, and opportunities to develop new coping skills and ways of dealing with the described restrictions and limitations seemed very, very helpful, and as well as from the professional as well as the parental side. So with this, I move forward to the next study, and which will be presented by Dr. Witt.
Yeah, thank you. So after we analyzed the results of the feasibility study and the results of these qualitative interviews, we adapted the manual of the pretend play intervention regarding the suggestions of professionals and parents. So now I'm pleased to present the quantitative results of the Swedish-German pilot study in a sample of pediatric oncology patient testing this adapted pretend play intervention. The pilot study explored whether a pretend play intervention for children with cancer is associated with improved quality of life and self-efficacy for communication in care situations. We hypothesized that both quality of life and self-efficacy will increase. So 19 families were included in the presented analysis, including 12 self-reports, and 19 proxy reports. All included children participated in 6 to 10 play sessions. Concerning the gender of the children, the majority of the patients were female. The participating children were on average 4.3 years old at the time when they were diagnosed with cancer. In order to measure the children's quality of life, we used previous patient-reported outcome measures. We assessed the generic quality of life using the PETS-QL, and the chronic generic quality of life with the DISIP kits. We used also the PETS-QL cancer module to assess the disease-specific quality of life, and the self-efficacy was assessed using the self-efficacy scale. Children from 5 years of age filled out the questionnaire together with a play facilitator before the intervention started. Therefore, we created the first session to get to know each other. And then the children filled out the questionnaire again after the last session, being assisted by the play facilitator again. At the same same time, the parents rated the child's quality of life as a proxy report. And only parental assessment was used in the case of very young patients, or when the patients were younger than 5 years. And in addition to the child's quality of life, the parents were also asked to report on parental quality of life and family functioning using the PETSQL family impact module before the intervention started. So we compared the parental quality of life with an outpatient sample, and these analyses show a significantly reduced parental quality of life. This was shown for the scales emotional functioning, social functioning, cognitive functioning, daily activities, and family relationships. And additionally, parents reported significantly reduced scores on all sum scores, including parental quality of life, family functioning, and the total score. The children reported significant positive changes from pre to post assessment of generic, chronic, generic, and cancer-specific quality of life. This affects the scales emotional, kindergarten, respectively school, psychosocial, and the total score of the generic quality of life. The children reported also a significant increase regarding the scales communication and the total score of the cancer-specific quality of life. Parents reported positive changes from pre to post assessment for all scales of generic, chronic generic, and cancer-specific quality of life measurements. And these changes were significant for the generic scale physical and the generic total score, for the chronic generic scales independence and physical, and the cancer-specific scales pain and hurt, suicidal, anxiety, and the total score. Furthermore, the children reported a significant increase in self-efficacy in asking a nurse for help when needed and saying if they do not want to do something they were asked to do. Self-efficacy changes reported by the parents showed positive changes as well, yet these changes did not reach a significance level of 0.05. Additionally, the participating children reported having fun throughout the intervention. However, they reported, for example, pain or tiredness at the beginning of the intervention. And in addition to these quantitative results, we want to present 2 case reports to clarify the development of children within the pretend play intervention. I will start with Anna. Anna is 6 years old and lives together with her parents. She was 4 when leukemia was diagnosed. The pretend play session with Anna took place alternating at the hospital or at the family's home. She looked forward to each pretend play session, independent from the setting. She set an alarm clock to remind herself of the appointments. Anna showed much imagination in the play and paid much attention to details. In the play, she integrated the role of the protective sister. With the second session, Anna wanted to play medical stories. Anna expressed anxiety about staying in the hospital alone within these medical stories, although she never did. When asked how she coped, Anna imagined not being ill in uncomfortable or unconfident situations. When Anna replayed a routine visit, she sank her head, spoke softly, and expressed her wish that there would be no fever or any other reason to suspect to be sick. She hardly hoped that there was no reason to get an injection or stay overnight in the hospital in the play. Medical topics integrated into the pretend play sessions by the child included ambulance appointments, X-ray and ultrasound examinations, nausea, hospital clowns, and fevers. Anna also opened up about her hospital experiences, such as not liking injections in her arms and her scars. She also expressed her negative feelings regarding her annoying roommate. She was encouraged to reflect that she had not told her mother how she felt about her roommate, but still expected her mother to help her. Anna developed a possible strategy within the intervention to open up to her mother about that. Anna also expressed her change in appetite, her worried mother, and her dislike for surgeries. The next child I will introduce to you is Olivia. Olivia was 2 years and 1 month old when leukemia was diagnosed. The pretend play session started when Olivia was 3 years and 2 months old. In the first session, Olivia had fewer ideas and talked very little. With time, she had more ideas and enjoyed playing with a play facilitator. She played with much detail during the sessions, and within the play, it was essential for her that, for example, everyone washes their hands before eating. Hygiene was a very important topic to her. In the third appointment, Olivia played the first medical story. Even though the play facilitator took the role of the doctor, Olivia participated in the decision-making process. Common themes in her medical stories included plasters, taking temperatures, bandaging with gloves on, fevers, ports, and finger pricks. The role reversal between patient and doctor was not a problem for Olivia. In her play, she used different coping strategies, such as holding the parents' hands, getting gummy bears as rewards, and assuring her dolls that the finger pricks are not that bad. She referred to her own experiences with finger pricks to assure her dolls. So these examples of the medical stories created by the participating children show that the intervention gives the children a secure environment to reenact situations they have experienced. The children are enabled to try out new, previously unused coping strategies. Even the very young children were able to reflect and positively deal with their experiences with the assistance of the play facilitator. So it is essential to support young pediatric oncology patients. However, as a clinician or a researcher, you should always keep in mind that most of the children live in a family, and the diagnosis of pediatric cancer affects the whole family system. So besides the important perspectives of the affected children, we ask their parents about their experiences with the pretend play intervention. So we conducted semi-structured interviews with at least one parent of the participating children. And these interviews were digitally recorded and transcribed verbatim. To analyze this qualitative data, we developed categories using the method of content analysis. And therefore, we used both deductive and inductive coding. And this is an overview, and it shows you the three main categories: perceptions of the play intervention, reflections on effects and implications, and the third theme, experiences of joining the project. The interviewed parents experienced an improvement in their children's ability to communicate, cope with their situation, and participate in their care. They also experienced the pretend play intervention as a positive break in their children's cancer treatment, including a private zone based on the secure environment and the trust in the play facilitator. From the parents' perspective, this intervention enables children to talk about their emotions and needs by themselves. One side effect reported by the parents was a positive break in their own daily life. When the parents knew their children were being professionally supervised by the play facilitator, the parents could relax. And most participating families joined the study for altruistic reasons. So they reported they want to support research and psychosocial care on the one hand. They were hoping that psychosocial intervention would be implemented in routine care. And on the other hand, the parents wanted their child to benefit from this intervention. Parents often showed anxiety regarding the future, including fears of recurrence or fear of trauma due to the treatment. So to sum up, both the participating children and the participating parents reported positive experiences within this pretend play intervention, which encourage us to continue this research. Sandy, would you like to add? Yeah.
Go ahead, Stephanie.
Okay. So to come up with a conclusion, we can say that play therapy or play intervention facilitates the expression and reflection of emotions, thoughts, and experiences related to the child's disease. And it leads to a reflection of their disease and treatment, and gives them possibility to learn new coping strategies. So now we have time for questions.
Yeah, thank you for your lecture. And the other speakers, if you have any questions to them, feel free to ask. Meanwhile, the next lecture, I request Dr. Maria from Blair University, United States, to share your screen, and you can start your presentation.
Actually, I was going to ask a question of the previous speakers, if that's okay. My department actually trains child life specialists who do this kind of thing. Were you using those kinds of people to do the interventions, or were they people who were trained specifically for working with cancer?
The people who carried out the study was Dr. Witt, Dr. Quitman, and Freiberg Holm. So these were the individuals who'd had a lot of experience with children. I had worked with them to develop this particular play intervention, which was based on previous work that we had done in the United States with children, siblings of children with cancer, children with sleep problems. And what we learned from those studies, we adapted then for this particular set of studies.
Okay. It seems to me that what you have developed as a protocol for helping these children would be of tremendous interest to child life specialists who do this. How do you disseminate that information to reach child life specialists?
That is a very good question. I think we haven't felt ready to do it until we had more research support. We have one study now. I think we probably need another study before disseminating it. What do you think, Julia and Stephanie?
Yeah, well, I think from Sweden there was this great feasibility study, and I introduced you to our pre-study, and then we had this cross-cultural study, which is about to be published with a quantitative as well as qualitative results, which Steffi presented. I think we have to, well, maybe do some, as Sandy said, perhaps collect some more findings to strengthen our results. But so far, it seems really like a great possibility, which professionals as well as families really really like, and and our results are showing this too. But we have even though it's a cross-cultural study, we have a small sample which needs to be still published, and then we have to strengthen our results with some more bigger numbers.
That's perfectly reasonable. I have to say, I find it very exciting what you're doing, and we train child life specialists in my program. We have one on staff who's worked in a children's hospital where they dealt with a lot of cancer. They need this kind of thing specifically designed for cancer patients. So I'm very excited about what you're doing.
Thank you. And this would be actually a relatively easy intervention to disseminate and to train people, assuming they know, have experience working with these children. It would be easy to disseminate. Where are you located?
I'm in Waco, Texas at Baylor University.
Okay, at Baylor University.
Yes.
Maybe we could all get in touch later.
Yeah, that would be great.
Great.
Okay. I'm actually gonna, let's see, how do I do this? I'm gonna put my email address in the chat. Okay.